Welcome to the Senior Rehab Podcast.
The podcast for rehab clinicians that want to better serve older adults.
And now, your host, Dustin Jones.
Hello, friends. Thank you for the download. Thank you for the time. I appreciate it, and I'm excited to introduce you to Dr. Lauren Southerland. She is the second ER physician on this podcast, the first one being Dr. Jonathan Sullivan. This is Dr. Lauren Southerland, and she is an ER physician at Ohio State University. She has an interest in geriatrics, and she is doing some pretty awesome stuff in the ED there at Ohio State. She has quite the path in the journey and is working to make some big quality improvements in how we care for older adults. You may think, why in the world is an ER physician on this podcast? Well, what she is doing is very pertinent to how we care for our patients, but she's also working with physical therapists in the emergency department in caring for older adults. But without further ado, let's talk with Dr. Lauren Southerland from The Ohio State University. Dr. Southerland, welcome to the Senior Rehab Podcast. I appreciate your time.
Thank you for having me here, Dustin.
So I got to be careful of what I say this evening because you are an attending physician for my wife. So I'm going to be on my best behavior, but I'm excited to talk geriatrics with you today.
She doesn't get in trouble, don't worry.
Of course, she's a saint. So she respects you a lot for many reasons, but one of them is your interest in the geriatric population. So tell us, the listeners, just about kind of the path of your career up to what you're doing now, and just kind of the genesis of how you became so interested in geriatrics.
Okay. Well, for anybody considering the healthcare profession, I wasn't. I was adamantly not going to be a doctor, and I was going into mathematics and chemistry. Wow. When one of my friends convinced me that I like to talk too much, and so I shouldn't be a primary researcher.
At what age was this that she said that?
This was a junior in college.
Okay.
And so then my counselor said, well, you've got all the science courses, but you need to have some sort of healthcare experience. So I'm going to put you in the one class that's open, which was an aging and healthcare class.
Oh, wow.
Sociology class. I thought, all right, I can handle this. So I went in and I learned about everything that's going on in our healthcare system and the silver tsunami, or whatever you'd like to call it, of our aging population, and decided this is what I needed to do. So then I went to medical school thinking I was going to be a geriatrician. And that's what I loved until the start of my fourth year when I did an emergency medicine rotation and realized that I was the one who loved to run to codes and, come on, let's do CPR. I'm going to put in the central line. And you can ask Megan about this, but the other IM residents were like, oh no, there's someone coding. I have some paperwork I need to do. I guess I can't help out. Sorry.
Yeah, and then they end up disappearing.
Yes.
It's ironic, isn't it? Yeah.
It's amazing how fast people can get out of the way. So I found my calling, but I still love geriatrics. And luckily, there were two amazing women faculty in my program who encouraged me to do both.
Who were those people?
One was Luna Ragsdale, who was an EM physician who did a geriatric fellowship. And the other was Victoria Thornton, who was an EM physician who worked with palliative care and pain control.
Okay. And where were they?
At Duke University.
At Duke. Okay. All right.
So I did an EM residency there, and then I did a geriatric EM fellowship at Beaumont. And then I came to OSU because they said, great, we'd love to let you do anything in geriatrics you want. So that's what I've been doing for the past 3 to 4 years.
Wow. So when you came to the wonderful state of Ohio from Michigan, was that tough? Was that a tough move for you to come to Ohio from Michigan?
No.
Of course.
It was tough. It was tough only in that I'd never been to the city before I interviewed here.
Yeah.
But it's a very easy to live in city.
Yeah, I agree. So you had a clean slate. You could kind of pick, what you wanted to dive into. Before you started the job, what what was on your mind in terms of what you were wanting to accomplish or research in terms of geriatrics with your new job at OSU?
Well, I had mainly two interests. One is I told OSU I want to design a geriatric ER. And they said, that's great. We're building an entirely new ER. Come do it with us. And I also have a research interest in injuries in the older adults and how they affect their functional decline, which is something you know very well.
Mm-hmm. So those two main interests, how have they come to fruition since you started?
Well, this is almost a year ago now. OSU opened its brand new 106-bed ER.
And to give people perspective, could you just compare that to, I guess, a typical emergency room? Because even, I've dropped Megan off at work a few times, and it just baffles my mind of just how large this place is. But could you give some perspective for people listening?
This is a very large emergency department. So most community emergency departments are around 25 to 35 beds.
That's ridiculous. How wide or how much do you walk a shift? That'd be interesting to know. Have you ever calculated that?
I think some people have worn the little step counters. I have not.
Yeah.
We sort of divide it out into sections as best we can, so you're not trying to care for patients 300 feet away.
Mm-hmm.
But it can be daunting.
Yeah. Okay, sorry. So continue with what you did.
Well, but that brings up the point that we were looking at this space and looking at the blueprints and saying, where are we going to put our geriatric ED? Do we want 10 beds here, 10 beds there? How are we going to staff it? And then it really came down to, we see enough older adults coming through the ER that deciding who gets a geriatric bed with geriatric trained nurses and better equipment and things is unfair. And we really should make the whole ER geriatric friendly. So that's what we've done. Yeah.
So practically speaking, what does that look like? What makes an ER geriatric friendly?
So there are a couple of things. The main one is education. So we've been educating the residents, and every nurse in the ER is undergoing a 2-hour training session in geriatrics. We talk about geriatric syndromes, including delirium, falls risk and falls prevention, frailty, and we're doing the ISAR, or seniors at risk score, and then elder abuse and ways to detect and report for that.
Okay.
So we're educating all the nurses and the residents, and I hope to move on to the paramedics and nursing techs soon too.
Yeah.
So that's one aspect. And then we have a whole nursing-driven program where the nurses are screening older adults for delirium, falls screening, which we'll talk more about, and other things. And then we can alert pharmacy, case management, geriatrics will come down and consult, physical therapists will come down to the ED and consult. So it's been really great.
Wow. So you have lots of protocols, checklists, just ways to kind of screen people for the appropriate care. And you mentioned, the fall risk program that you're doing. Could you tell us more about your work there?
Sure. So have you ever seen the CDC study guidelines?
I'm going to say no.
Okay. So as we all know, falls are a major problem for older adults and cause a lot of injuries. And even if an older adult is not injured from a fall, their risk for functional decline and increased healthcare use after that fall is high.
Right.
And we don't exactly know why. So even a bruise or a small laceration is enough to cause problems, or maybe the problems that cause the fall continue to cause problems. Don't know, but it's a big deal. So the CDC wants all patients to be screened by their primary care doctor for falls risk, and then referred to PM&R or physical therapy or home safety, home health, whatever they need to do our best to prevent falls in an interdisciplinary way. So that's not happening.
So what does that look like practically? What's the screen look like?
So practically, every older adult who goes to their primary care doctor every year should be screened for falls risk, but it's really just not happening at the rates it should be. And what we're seeing is these adults who fall, a lot of them end up in the ER because they're injured or they fall and their family calls EMS. So we see a lot of them in the emergency department. And what it used to be is that if Say, for example, my grandma who fell 2 years ago, she fell on the stairs, she hit her head, she went to the ER. They said, oh, did you pass out? Did you have a heart attack? Did you fall? No, I just tripped on the stairs. Okay, they scanned her head. She didn't have a bleed. She was walking, talking, no major injuries, send her home.
Yeah.
But we don't do any falls counseling or prevention or talk about what does this fall mean for you over the next few months.
Right. Yeah. And that's mainly what I'm doing in home health is the next few months after that fall, which can really change someone's path for the better or worse for sure. I'm interested with physician training and screening for falls. What types of movement assessments do you all learn in terms of how to determine if someone is at fall risk?
So the basic falls risk screening in any ED in the country, most of them do this. They'll have the nurse say when you present, have you fallen recently? Yes or no. Mm-hmm. Do you need a walker or a cane to help you walk? Yes or no. Okay, you're a fall risk or you're not a fall risk. And that's all it is.
Okay.
Or if the person looks a little weak, they'll slap a falls risk bracelet on them.
Okay.
What we're doing is we're actually doing what's called the 4-stage balance test, which is a balance testing where you stand the patient up at the bedside and you have them stand for 10 seconds in different positions, 4 different positions. It starts from just standing with your feet together for 10 seconds. And if you can do that, you move one foot a little bit forward. If you can do that, you do a tandem step. And if you hold that, they have to stand on one foot for 10 seconds.
Okay.
And if they pass that, there's really good data that they're not a big falls risk at this time.
Yeah. Who's implementing that screen? Is that physicians or nurses?
The nurses are doing the screening.
Okay.
And if they screen positive for high risk for falls, then they're on falls precautions in the ER and throughout their hospital stay. But then we have pathways. So if they're admitted, obviously we can have physical therapy see them inpatient and determine a treatment plan. But it's more difficult for the patients who are going home.
Right.
So for that, we have what's called an observation unit, which is a 24-hour stay unit where we can do a little bit more in the ER. And so we can keep them have physical therapy do an assessment, have the case manager or social worker come by and say, do you have grab bars at home? Do you need a walker? Do you need a cane? What do we need to do to help you out? Can we get you set up with Dustin, this great guy I know in home health physical therapy?
Awesome.
So we're trying to arrange all of that out of the ER, and it's been working really well. And the primary care doctors I've contacted have been ecstatic about it.
Yeah. So this program, are you studying this right now in terms of measuring outcomes of its effectiveness?
We started the nurse training in October, and so we've got about half the nurses trained, and we'll continue to get them all trained. And then I'm setting up a monthly report where we'll pull all the older adults that came through the ER and who got screened and what their screening is, and then we can look back and see who's getting referred to home health. Or we also have a PM&R run falls clinic where people can go for a multidisciplinary assessment.
Okay. Do you feel like home health rehab is utilized well from the emergency room?
I think we're doing it a whole lot more now that we have specific protocols out of the observation unit. More and more people are saying, hey, could this patient need a little bit more help before I discharge them home?
Yeah. What was the case like when you first started practicing as a physician?
When I first started practicing as a physician, we didn't have specific observation protocols for this. We had a physical therapist that would sometimes come down to the ER and see patients if we asked specifically, but we weren't using her all that much. And she wasn't stationed in the ED. Now Gabby's there every morning seeing 3 or 4 consults a day, sometimes more.
Yeah. So in an ideal world, let's say, you are the manager of a brand new emergency room, which, sounds like you had a lot to say in terms of the recent one at OSU. If you could call all the shots, what would the role of a physical therapist be in that ED?
Oh, I think there are multiple roles. And that's one thing that Lauren Slatterly, our physical therapy student, has been working on. So there are very few ERs that have an embedded physical therapist, one of which is Indiana.
Right.
So she did a month there to see how they work it with the billing and everything. And there are two different kind of roles for physical therapy. One is we see a lot of musculoskeletal injuries.
Mm-hmm.
And so it's really nice for all the patients who come in with acute on chronic low back pain or an ankle sprain to say, your ankle sprained, here's your crutches, here's your diagnosis, and here's a set of motions you can start doing at home.
Yeah.
And we'll see you in clinic in a week. Or, you haven't tried physical therapy for your low back pain. We're going to get you set up in 2 days, and here's what I want you to start doing.
Yeah.
So there's that aspect which has proven to be really helpful, and patients really like it.
Mm-hmm.
And then there's also this aspect of the older adult patients who maybe have not been assessed by a physical therapist, and they're there for a possible stroke, TIA, or their family finally drags them into the ED and they haven't seen a doctor in 20 years. So those are the patients that I think a physical therapy full assessment can have a really big impact on their care and long-term recovery.
Yeah. Yeah, I've heard some good things coming from Indianapolis in terms of I remember reading a good amount of research coming out of that ED in terms of especially like costs and outcomes after discharge from the hospital, and just correlating it, with the physical therapist and the ED. But when I just think that there definitely is a role from a couple ends, from the geriatric end, like you mentioned, but yeah, definitely kind of the orthopedic musculoskeletal issues that we come across. And I just remember, I used to work in an outpatient PT clinic, and saw a wide range of people, but we would see people just have, simple ankle sprains that, were just given, kind of, medication. They were splinted, usually in plantar flexion. and it just made it really difficult for the recovery on the back end.
Because they don't take the splint off or
Right.
call anybody for 3 weeks.
Right. Yeah. And I'm not putting that on, who took care of them in the ED. It's just that time gap. A lot of things can go wrong for sure. But I just remember saying, man, if we could have got to this person so much sooner, we would have saved so much heartache. But it is cool to see just how PT is starting to go into that realm and be able to show its objective value and not just assume that we are going to be helpful, but to be able to show it. So that's pretty neat. What are some of the highlights of the research that you've done so far in your career in terms of things that really have informed how you treat older adults?
So on the falls risk assessment research right now, we have a study going on where some of the physical therapists at Duke are looking at trunk stability as a predictor of falls risk. So they actually have iPods with a calculator on them that measures how much a patient wobbles when they're in different stances.
Wow.
So we are measuring their trunk stability as they're doing their 4-stage balance testing, and then we'll be looking back at who's falling and who's not, and seeing if we can get norms and if that's a better testing device than just doing standing balance alone.
That's amazing.
So that's one project that I'm really excited about. Anything in the ER that's fast and easy, we like.
Yeah. Yeah. So they're just in those 4 different positions and just monitoring their trunk sway, basically. Okay. That's interesting.
Yeah. So the whole assessment takes 40 seconds, and the patient can stay on their monitors. They don't have to come off the IV or anything, and we can do orthostatics at the same time.
Yeah. Yeah, and for all the listeners out there, a lot of these screens that they're doing in the ED, they can be done, especially like for me in the home. Not everyone that we treat or I treat, is necessarily a fall risk or perceived as a fall risk. I mean, but this is a super quick screen that we can do. I mean, granted, we all have our different objective measures, whether it's the Berg balance scale or the Tonetti or whatever objective measure is yours of choice, but this screen sounds very practical and quick and pretty effective. So that's pretty awesome. So I want to switch gears a little bit and just talk about some of the things that I struggle with in my world in terms of, seeing someone in their home. They've been discharged from the hospital, whether they were admitted or not. But there's always that fine line where should we go to the emergency room, or are you safe to be at home? If you were to talk to someone like me, a home health PT, what things come to mind that I should definitely be calling the squad to have this patient brought to the emergency room?
I think that's a wonderful question. So, and we often get people who are found by their home health physical therapist or other home health caregiver. Things not to overlook are any sort of altered mental status.
Okay. So
if the patient's more confused, or if they're just not as conscious of their surroundings, if they seem sleepier than usual, that could be a sign of a severe infection or a medication problem. Mm-hmm. So those are patients that are concerning. They may be delirious, and we need to assess them quickly.
Yeah.
The other thing I struggle with, even with my family, is getting someone assessed after every fall. Because a lot of patients feel like they've already seen a doctor in the past month and they've fallen twice. Why would they go back again?
Yeah.
But they hit their head on their aspirin, so they need to be assessed.
That's a good point.
So altered mental status, any fall, and also if you have a concern that a patient is not being cared for or can't care for themselves appropriately anymore, let someone know. Bring them to our ER, and our social workers and case managers will help out. We can work with our local area agency on aging and adult protective services and try to help people get the resources they need.
Yeah.
Because some people don't know how much help they would qualify for.
And I know I can think of a few situations in terms of should I call the squad or not, and that's definitely involved vitals, just blood pressure going through the roof, heart rate crazy, and not being able to get a hold of the primary care physician. In those cases, it's been several times. Therapy was definitely contraindicated, but in terms of sending someone to the hospital, that was a tough call. And I'm not going to lie, I called my wife a few times and asked her, and she gave me some good advice. But I think I struggle with this because so many of my patients hate going to the hospital. They hate going to the emergency room, and they just express that the last thing that they want to do is to call the squad to go to the emergency room. But deep down, I know you're not safe here. You need to go to the hospital, and that's just a constant struggle that I have with a lot of patients. Do you see that in the emergency room?
Oh, definitely. And I completely understand. The emergency room is not a fun place.
Right.
There's a lot of waiting. You're not in your home environment. There's noise. You can't sleep. There's weird people coming in and out all the time.
Yeah.
You get poked with needles. So one thing you can do is tell them that you're going to call the squad just to come in and double check. Say, I want to make sure my blood pressure cuff is all right, or that my measurements are okay. I want someone to get another set of eyes. We don't necessarily have to go, but I want them to come and assess you.
Yeah.
And most people will be receptive to that, even if they're giving you the stink eye.
Yeah. What's your work like been with EMS? Do you communicate with them a lot?
We love our paramedics. They work really hard, and they're fantastic people, and we've actually done a lot of work with them. I actually just gave a lecture about elder abuse to the Worthington Fire Department last month.
Yeah.
And Jeff Caterino, another member of my department, has done assessments working with the fire department on all the patients who fall and refuse transport, or doing home safety callbacks or home safety visits. So there's a great benefit to the people of Columbus come out of our paramedics.
Yeah, that's awesome. Another thing that is a constant struggle, and I mean just healthcare in general, is medications, in terms of over medication, or just patients being on just this crazy long list of all these different meds that could be interacting with one another. But I've always thought, what is it like to have someone come to your emergency room to where, let's say they've had a fall and, they're just on, 15 to 20 medications. How in the world do you handle that as an emergency room physician?
Well, I first assume that they're not taking any medication as directed.
Okay.
Because honestly, if you've got 15 to 20 on your list, it's almost impossible to take them all exactly how they should be taken. If you look at the bottles and say what can be taken with what, and what is with food, and what is without food, and what the times are, it makes things very difficult. And as you know, falls are often multifactorial.
Yeah.
And polypharmacy is behind a lot of emergency department visits. The main offenders are blood thinners, pain medications, and I believe kidney problems from NSAIDs and other renal toxic medications. So we are actually working on ramping up our pharmacist involvement so we can offer full medication reviews for all our older adult patients in the ER.
Awesome. Do you have much communication with the primary care physicians in terms of when a patient, comes in with those kinds of problems?
It's often very difficult because our primary care physicians, as you've also discovered, are 9 to 5.
Yeah.
But I found that most clinics, if you call a page and say you're calling from the ER, they are delighted to talk about their patients and will drop everything to get to you. So,
yeah. Have you dove into the discharge summaries much at all from the hospital in terms of, especially from the geriatric perspective? I've had so many patients that come home from the hospital and they get their nice discharge summary, whether, it was from the ED or, when they were admitted. And typically they're no shorter than 8 to 10 pages. and there is a good summary sheet. But so many of definitely my geriatric patients that just have a really tough time navigating the information, future appointments, or the medication list, if it was altered or whatnot. What's your take on that? And are you familiar with anyone working to make that as user friendly as possible?
And that is a big problem, and there's good research data that shows that the majority of older adults discharged from the ER or the hospital don't understand their diagnosis, their medications, any changes, and it results in poor care and revisits. Our ED discharge instructions are not well formatted. There's a lot of boilerplate text that goes in, which can be very confusing to older adults. I mean, in my opinion, we don't need 2 paragraphs, thanking them to come to the OSUD and directing them to urgent care and other OSU clinics if it's not pertinent to that visit. And it just gets confusing to people.
Yeah.
If for the medications, you need to have a good medication reconciliation. Otherwise, whatever on that discharge list could be whatever they'd be given in the past 5 years in our health system.
Oh my gosh.
Unless someone goes down and deletes, the azithromycin antibiotic they were on for their bronchitis last year, it's going to keep popping up again and again. So medication reconciliation is a big problem. And we thought everything would be fixed with electronic medical records, but we're finding that we just continue to have the same errors over and over again.
My gosh. And to let you know, I've gotten discharge summaries from all the hospitals, in our area, and your all's is one of the cleanest, I will say.
Really?
Yeah.
Oh, that's not good.
Yeah. The first page summary, I really enjoy. But yeah, it just blows my mind because I'm not the sharpest tool in the shed. I'm not going to say I'm the brightest individual, but I've got a doctorate in physical therapy. I've been through a decent amount of schooling, and I've got a tough time understanding a lot of the things that this patient needs to do once they get home. And it's just, there's so much information on there. It's just crazy for just the typical geriatric client to kind of, get the big nuggets out of there, the things that they need to do, the meds that they need to take. It can be very challenging. So yeah, I'm glad that is on the radar for sure. And I have seen one, I think it was a TED Talk. I cannot remember the name whatsoever, but they were talking about how, they just need to make giving medical information to the patients more user-friendly experience and just using kind of that graphic designer mentality with some of these discharge summaries. So just make them look prettier, keep them simple, use different, pie charts or different things just to illustrate certain points that just make it very pleasing to the eye. So hopefully, that'll be in our future.
That would be wonderful, because right now we have a combination of too much information and lack of information. And, people get their labs back and say, oh no, this lab is abnormal. What does that mean? And I say, it means nothing.
So
if I checked it again today, it'd be 3 points different. Don't worry about it.
What is some of the most important information that's left out commonly from your perspective?
I think we often leave out a paragraph explaining in lay terms what tests were done and what we ruled out. So take, for example, an 85-year-old comes in with chest pain. He was, working out in the garden, and his chest started to hurt. He sat down, it went away, and EMS was called, and they brought him in, and we get heart lab work and EKGs, and everything looks okay, and tell him he's okay to go home. And his diagnosis is chest pain.
Helpful.
Yes. Yes, because, I don't have a clear reason for why he had the chest pain. Yeah. Maybe it was a muscle cramp. I don't know. But it can be very concerning to patients. And they don't understand sometimes why we use these vague terms unless you explain it clearly. You were seen here for chest pain. We did all this workup. It's not a heart attack. You're okay to go back and garden again. We want you to be checked by your doctor in 2 days just to make sure you're not having any more chest pain or any problems.
Yeah, Meg and I have had several conversations about, just how so many of your all's patients that you see, a lot of them want that intervention or want that answer. This is what we're going to do. This is a problem. And rightly so. But just how, I guess a lot of people kind of undervalue that ruling out of certain things, of being able to tell people you don't have this, which is very valuable. And I definitely see that in my patients in home health, that they either they were not told what issues were ruled out, or they were told and just didn't comprehend it, or they were told through the discharge summary and didn't understand the words, or didn't read through the 1,500-page essay about the issue. But do you, in terms of when you see people, is that a big chunk of what you're doing in terms of just rolling out, those major red flags?
Exactly. Our job in the ER is not to say what is going on. It's to say, is this going to kill you in the next 24 hours?
Do the patients know that, you think?
I think a lot of them understand. A lot of them just want that reassurance. Doc, I just want to make sure this belly pain wasn't colon blockage again, or a colon cancer or something.
Yeah.
So a lot of them are very understanding, but you have the same problem in physical therapy. Someone comes in and their knee hurts, and you don't find exactly one muscle or an ACL tear or something exactly, and end up with your diagnosis is owie knee.
Yeah.
And a lot of people struggle to understand that.
Yes. Or we make up some crazy diagnosis and convince a patient that that's their problem.
Oh man, it's your iliotibial band. I know it for sure.
Exactly. Yeah. Your chi is off. So yeah, that's usually the problem. So awesome. So what's your biggest ask of people like me? Whether they're in home health or skilled nursing facility, or maybe even an outpatient PT, and we'll throw occupational therapy, speech therapists, just the therapists, the rehab team that work with these older adults. What is your biggest ask of us to make your life a little easier and to improve the quality of care for our patients?
I would say you're all doing an excellent job. And my biggest ask would be to speak up. If you think something's wrong, or you think therapy's not proceeding the way it should be, and there could be another diagnosis, and you think they need a reevaluation, speak up and let people know. Because you guys are smarter than you think, and you get to know these people very, very well.
Yeah.
So if you're seeing someone 3 times a week for a month and you tell me this person is not right, I'm going to trust you.
Mm. That's a good point. And it's easy to forget that as well, because oftentimes we are the ones that are spending the most time with these people, whether, on the healthcare team or even, family or friends or, anyone in their lives. So that's a good point.
So please, and we ER doctors are not scary, I promise. So feel free to call or to call and leave a message for their primary care doctor. We want to know if things are going badly with our patients, or even to call a family member and say, Mrs. Smith, do you mind if I call your daughter and tell her how physical therapy went today? I think she should know what happened during our session.
Yeah. Okay. That's awesome. Well, Dr. Southerland, thank you for your time, and just thank you for your work and just what you're doing in the emergency room, but just how you really see, this kind of healthcare continuum of all these different pieces of the puzzle, all these different players in the healthcare system. I feel like you have a great perspective on bringing everyone together to improve the quality of care for our patients. So kudos to you. I'm excited to see, what's going to come of what you're doing there in the emergency department. And yeah, I'll be checking in on you to see how things are going. If anyone has questions for you, is there a way to get a hold of you? Are you on Twitter by chance? Or Facebook or anything on social media?
I am on Twitter.
Mm-hmm.
I don't really use it.
Okay, that's okay.
I think I'm LS Geriatric EM, but it'd be better to have them just email you or questions to you.
All right.
I'm happy to answer and talk to anybody.
Okay, people, if you have questions for her, email me and I will forward them to her. Don't bother on Twitter. So that's great.
I have 3 kids and a job. I can't keep up with anything else.
That's very true. And I'm really impressed though with the emergency room physicians that are active on social media. I would say the ER crew is probably one of the more active specialties on Twitter. And I say that because there's a really tight-knit PT community that shares articles and debates and discusses different things, and sometimes some other physicians will jump in on the conversation, and lots of people in the emergency room are having these conversations on Twitter. So when the kids are out of the house and they're long gone, you should hop on there and join the convo.
I'll follow you on Twitter, and then when I check it every other week,
yeah, okay,
see what you've been talking
about. That works. All right, Dr. Southerland, thanks again for your time. I appreciate it.
Thank you very much.
Hit me. Thank you for listening to the Senior Rehab Podcast. The show notes for this episode and much, much more can be found at seniorrehabproject.com. If you found value in this conversation, please share this with one other person that could benefit. And until next time, do not forget to stay funky.